All right, welcome everyone. Today we're going to dive into a masterclass that explores the really complex and fascinating relationship between ocular pharmacology and contact lens wear. We're going to cover the whole spectrum, from the fundamental principles and clinical interactions, all the way to the future of these amazing therapeutic technologies.
So here's what we've got on the agenda. Our journey is going to start by building a solid foundation with the principles of ocular pharmacology. From there, we'll get into the nitty-gritty of clinical interactions with both topical and systemic drugs. And finally, we'll look to the horizon and explore the future of contact lenses as some seriously powerful therapeutic and diagnostic devices.
Okay, so first things first. Before we can even talk about interactions, we've got to get a handle on the fundamental rules of the game, the engagement between a drug and the eye. This is where it all begins.
So pharmacodynamics. You can think of this as, pretty simply, what the drug does to the body. It's all about its mechanism of action, right? How it latches onto those specific receptors and creates the therapeutic effect we're actually looking for.
And then we have the flip side of that coin, pharmacokinetics. If the last slide was about what the drug does to the body, this one is all about what the body does to the drug. We're talking about its entire journey, from the moment it hits the eye, how it gets absorbed, distributed, and eventually how it's cleared out. So, when you put in an eye drop, it kicks off this surprisingly complex journey. First, it lands in the tear film. But here's the thing, a huge chunk of it gets washed away almost immediately through the nasolacrimal duct. What that means is only a tiny fraction of that drop actually gets a chance to reach its target inside the eye. You know, it's easy to think of the cornea as just a simple, clear window, but it's actually this incredibly sophisticated, multi-layered barrier. The outer layer, the epithelium, is fatty or lipophilic. Then you hit the middle stromal layer, which is watery, hydrophilic. And finally, the inner endothelium is fatty again. So for a drug to get through, it has to have the right chemical passport to navigate this whole sequence. Okay, and this is where it gets really interesting. A drug's chemical property, this thing called the partition coefficient, basically dictates where it's going to go and what it's going to do. Drugs that love fat, the lipophilic ones like acetates, have a high coefficient. They can cruise right through those fatty membranes to treat deeper structures. On the other hand, drugs that prefer water, the hydrophilic ones like phosphates, have a low coefficient. They tend to hang out on the surface, which makes them perfect for treating something like the conjunctiva. It's like there are all these physiological factors constantly trying to sabotage our efforts, right? They reduce the amount of active drug that can actually do its job. Every single blink pushes the drug out. The tear film itself can only hold a tiny volume. And our drainage system is super efficient at just washing everything away. Heck, even the natural pH of our tears can change how well a drug gets absorbed. Okay, so we've covered the theory. Now let's bring this into the real world and see how these principles actually play out in a clinical setting. We're going to focus specifically on the adverse effects that common topical drugs can have on our contact lens patients. And here is an absolutely crucial point to remember. When a patient comes in with irritation or signs of toxicity, it's so easy to blame the active ingredient in their drops. But more often than not, the real culprit isn't the drug itself. It's the preservatives used to keep it stable. Chemicals like benzalkonium chloride can be really harsh on the corneal epithelium, and that's what often leads to all that inflammation and cell damage. This table really breaks it down nicely, showing the specific challenges we face with different types of topical meds. You've got your aminoglycoside antibiotics, which can be straight up toxic to the epithelium. Then there are NSAIDs, which can cause that gritty, foreign body sensation. Steroids? They can ramp up lens deposits. And anti-glaucoma drugs like Timolol, they can actually get soaked up by the lens material itself and start to break it down over time. As you can see, each one requires a totally different game plan. All right, let's talk about something really dangerous. You might have patients who are so desperate to deal with their contact lens discomfort that they start misusing topical anesthetics to numb the pain. This is an incredibly hazardous practice, and the consequences can be absolutely severe. The real danger here is that it masks the underlying problem. Anesthetics essentially shut down the cornea's protective alarm system. So the patient feels fine, they feel no pain, but meanwhile, any underlying damage, like an abrasion, is just getting worse and worse. This can lead to a non-healing neurotrophic ulcer, which, as we all know, is a very, very serious condition.
So the damage really is happening on multiple fronts. The anesthetic chemicals themselves can literally degrade and discolor the contact lens. They cause severe toxic reactions on the ocular surface. And as we just said, probably the most dangerous part is that they completely knock out the cornea's protective neural response.
The eye doesn't exist in a vacuum, right? It's not in a bubble. The systemic medications our patients take for completely unrelated conditions can have a huge and often overlooked impact on their contact lens wear.
Think about it. A huge number of super common systemic drugs all share one nasty side effect. They cause ocular dryness. You've got antihistamines and antidepressants with their anticholinergic effect that just dries everything out. Oral contraceptives can cause hormonal shifts. Diuretics and blood pressure meds mess with the body's overall fluid balance. All of this can make wearing contact lenses go from comfortable to completely intolerable.
Okay, so we've talked a lot about the problems. Now let's pivot and start talking about the solutions. We're going to explore how the humble contact lens itself is being transformed from just a way to correct vision into a really advanced therapeutic tool.
This slide really nails the fundamental advantage of these drug-eluting lenses. Think about traditional eye drops. They give you this peak and trough effect, right? A big initial dose that just fades away super quickly. A therapeutic lens, on the other hand, is completely different. It acts like a little reservoir, providing this sustained, consistent release of medication right on the ocular surface, exactly where it's needed, for hours or even days at a time.
And it's not just about delivering drugs. Even a simple bandage contact lens plays so many critical roles in managing severe ocular surface disease. It can act as a shield, providing incredible pain relief. It can create a smooth surface that helps the epithelium heal, and it can protect the cornea from things like abrasive eyelids or just a harsh environment.
Okay, we are now entering what is truly a revolutionary era. A time where contact lenses are evolving into these sophisticated diagnostic and monitoring devices that can actually communicate with us in real time. This is the future, happening right now.
Let's look at a case study. One of the very first smart lenses to hit the market gives us a really clear glimpse into this future, specifically for how we manage glaucoma. So how does it work? Well, this technology allows for continuous, 24/7 monitoring of intraocular pressure. Instead of just getting one single snapshot measurement when the patient is in your chair, you get a complete picture of their pressure fluctuations, all day, all night. This leads to treatment that is so much more personalized and ultimately more effective. And this is just the beginning. The potential applications are just vast. We're talking about lenses that can monitor glucose levels in tears for our diabetic patients, lenses that can detect biomarkers for dry eye, and even lenses that provide augmented reality overlays to help people with low vision. The possibilities here are genuinely transformative.
Okay, so we have covered a lot of ground. What are the most important, crucial takeaways that we can apply in our clinics tomorrow?
First and foremost, you have to be a detective, always. You have to constantly be connecting the dots between a patient's entire medication list, not just their eye drops, their systemic meds too, and what you're actually seeing on their ocular surface. You'd be amazed how often drugs for things like allergies or high blood pressure are the real root cause of a patient's contact lens problems.
The second key point is this. A thorough patient history is, without a doubt, your single most powerful tool. And I'm not just talking about a checklist. I mean really digging in, asking the right questions about all their medications, any supplements, their lifestyle. Doing that before you even look at the eye can reveal the source of a problem, and even better, it can help you head off complications before they even start.
And last but not least, proactive management is absolutely everything. For these patients on complex medications, we just can't be passive. We have to be actively optimizing their ocular surface. And that means prescribing the right kinds of lubrication, making sure good lid hygiene is a non-negotiable part of their daily routine, and scheduling rigorous follow-ups. That's how we create and maintain a healthy environment for successful long-term contact lens wear.
So this incredible technological shift, it's both a huge challenge and a massive opportunity, isn't it? It really forces us to ask ourselves, how does our role as optometrists have to evolve? How do we prepare ourselves and our practices to not just adapt to this new era of eye care, but to actually lead it? That's the big question I want to leave you with.